Good afternoon. Thanks for this opportunity. So I'll be presenting a case today actually from my interventional fellowship last year at the University of Illinois, Chicago. So this is a case of a 91-year-old gentleman from our VA who had severe AS, was coming to us for his diagnostic coronary angiogram prior to his planned TAVR. His history was notable for severe peripheral vascular disease in his bilateral lower extremities. Actually, it precluded transfemoral TAVR, so the plan was for a percutaneous subclavian TAVR. He was pretty symptomatic, mostly dyspnea on exertion. His echo showed that he had normal EF. He met criteria for severe aortic stenosis, but his indexed valve area was 0.59, so he was just inside the severe range. And his STS risk of mortality was 8.5%. And he was pretty clear that he didn't want any surgical interventions, and the plan was pretty clearly going to be TAVR with a PCI if indicated. So we started with our diagnostic angiogram, 6 French right radial access. You can see here he clearly has severe ostial OM disease. You get the sense there's probably something in the proximal circumflex, although you don't see it very well here, and there's clearly some disease in that proximal LAD. Just another caudal shot to try to better show that proximal circumflex. Probably shows here a little more that there's some severe disease, but still not a great angiographic evaluation of that segment of the artery. For the LAD, there's clear severe heavily calcified proximal disease with an aneurysmal segment distal to that, and then the distal vessel, you have severe disease with at least moderate calcification there. The right also had proximal severe disease, but unfortunately this was not calcified. So in the sake of time, I'll just kind of hit a few of these points. There is something to be said about once we've defined the anatomy to maybe have that discussion again about CABG and surgical AVR, but we had pretty extensive conversations with him before this, and our plan was pretty clear to be a TAVR and PCI if indicated. There's no universal approach to revascularization pre-TAVR, but I think most people would agree that with severe proximal disease, he would benefit from treating all these lesions. Hemodynamic support might be nice with an Impella, but really that wasn't an option, not only because of his severe AS, but also his peripheral vascular disease. We couldn't do a transfemoral Impella. Something that came up Thursday when we were discussing this case was possible valvuloplasty. We didn't think we were going to get much additional benefit from that just because he was more closer to moderate AS than critical AS, so we thought we could get away with that. And then as far as access, we're a primary radial center. We felt comfortable staying with our right radial access. So we started with the LAD, went down with a rotofloppy wire, used a 1.5 millimeter burr, and did rotational atherectomy, 2 passes in the proximal lesion, and then we also hit the distal lesion with a single pass. We switched out for a wiggle wire, and then we were able to predilate that distal lesion pretty easily with a 2.5 balloon, put in a 2.5/26 stent, had a good result there. Focused our attention proximally, we were able to dilate that well with a 3.0 non-compliant balloon. Positioned our 3.0/22 stent proximally, just pretty much at the ostium of that LAD, deployed it, and had a pretty good result there as well. We just post-dilated at high pressure. We were pretty happy with our LAD results, especially considering what we started with. We then turned our attention to the circumflex. We still weren't sure about what our bifurcation strategy was going to be here, whether we need atherectomy, so we thought we were going to really depend on some intravascular imaging to better define those vessels. So we went with the IVUS down the circumflex, and we confirmed that there was diffuse disease in that proximal segment. The MLA at the bifurcation with the OM was 3.96. There was a decent amount of calcification, but we had convinced ourselves that we were going to do an upfront 2-stent strategy here. So we left the wire in the LAD for support. We were trying to avoid having to do additional atherectomy, so we went in with a balloon and tried to dilate that OM lesion, but you can see here there's poor expansion and dog boning of that balloon, so we thought it was in our best interest to just go ahead and do some more rotational atherectomy. So we pulled our wires, put in a rotofloppy, did a couple passes through that OM1 with the same 1.5 millimeter burr, rewired, and then this time we were able to get pretty good expansion there in that OM lesion. So for our stenting strategy, we kind of wanted to keep it simple at this point. It was a long case. We didn't want to minimize how many times we were rewiring that OM, so we just went with a mini crush technique. So we put a 2.5/15 in the OM, extending back into the circumflex. We actually crushed with a NC balloon rather than the second stent, which kind of got us into a little bit of trouble because we had difficulty delivering that second stent to the circumflex. We kept getting caught on the OM stent. So we wound up having to do, which doesn't project very well here because it's just a fluorostor, but we had to interworm down a guide liner and then unsheath the circumflex stent, which was a 3518 drug-eluting stent. We post-dilated with kissing balloons and had a pretty good result on the circumflex. So we called it quits for one day, brought him back a few weeks later for a stage PCI of the RCA, which was much more straightforward. Just wired it with the Xi'an blue, pre-dilated with a 3.0, and stent it with a long 3.5 stent just to cover the entire disease segment. We had a pretty good result with that. So clinically, he did very well. His symptoms improved quite dramatically. When I submitted this case last month, I was planning to show the results of his TAVR, which was scheduled for this month, but he actually felt so well that he wanted to put the TAVR off and might actually not even go for it at this point. So just some quick discussion points. You know, in these TAVR patients, we're going to encounter complex coronary disease pretty frequently, not uncommonly. And which of these patients are going to be able to tolerate complex PCIs is you know, unclear. But I think some factors that were in our favor. He had non-critical AS and actually kind of closer to the moderate range than the critical range. He had normal EF, and maybe we just got a little bit lucky because he tolerated it pretty well. There may be a role for balloon valvuloplasty. We got away with not doing it, but maybe especially if you're closer to the critical AS, it's a good idea. And then one thing we showed here too is that symptoms in AS are going to be multifactorial, and sometimes coronary disease might be contributing a large part to the symptoms. Thanks.
So I have a question. I and Manas were discussing. Were you happy with the LAD stent result, or something more could have been done?
Possibly. I mean, I think we kind of post-dilated as much as we were going to get. I know it looked a little kind of underexpanded, and there was that aneurysmal segment, so it didn't angiographically look pretty. We didn't IVUS it or image it either, which we could have done as well. But I think, all things considered, I think we thought that was about as good as we were going to get with that.
Perfect. I mean, excellent presentation. Quick question. Are you worried? So if something went to go wrong, I notice you're going 6 Transradial. If something were to go wrong, what would you have done?
Yeah, that's a good question too. I mean, I guess we probably would have gotten femoral access maybe and tried to see if we could get in some sort of support. I guess we could have tried with the balloon pump. Someone on Thursday when we presented mentioned just going up with a pigtail and leaving that in the LV just in case you want to try to cross with an impella. And if we couldn't do that, I guess having not done that up front, maybe even just putting in a balloon pump and seeing if that would help, although probably wouldn't help too much.
And one more thing, many people have said, why don't you start with the simple one, do the right first, do the easy ones, and leave the tougher ones for later and get a little more reserve. Any thoughts?
Yeah, no, that was one of the points on the slides I didn't really go over. But yeah, I think sometimes going after low-hanging fruit is nice to at least have some territory that's perfused when you go after the more complex disease. We just kind of felt at that time that the left side was the more important side to go after first, so that's kind of just the order we went with.
But one more quick question, you know, educate me. I'm a vascular guy, but is it really necessary? I mean, this was a critical AS patient, is that correct?
Yes.
Is it necessary to fix everything before? You know, I'm sure he's not doing very active given his AS.
Yeah, I mean, so like I said, there's kind of some debate as to what you go after pre-TAVR. I think a lot of it is so they tolerate the TAVR and you don't run into ischemia, especially during rapid pacing. And whatnot. So we felt, proximal disease, generally most people, I think, would revascularize that. I don't know if anyone else has an opinion there.
It opens up the possibilities for your various therapies. Yep. Okay, Dan, thank you so much.
Thanks a lot.